Hey, Ash here from All Things Dentistry, the place where we're passionate. I'm telling you, passionate about sharing those unwritten hints and tips of dentistry. Today we're going to be talking about a brand new article in the Journal of Endodontics that talks about the effect of apical enlargement. Let me check my notes here. The effect of apical enlargement to different preparation sizes and tapers on postoperative pain and outcome of primary endodontic treatment, a prospective randomized clinical trial. And I think that this is a very interesting article. It talks about obviously the apical enlargement, but it also involves things that we might not be able to do in a lot of other places where you can actually have treatment that might fail. So without further ado, let's get into it, and then we'll talk about a case and then, ask some questions, because this is the place to ask questions. Wow, I'm looking at my pandemic hair. I haven't gotten a haircut yet. So what we're going to do is I'm going to talk about the conclusions, and then I'm going to go through my own comments about the article, and then we'll talk about some of the discussion points, and we'll go through there. And let me know I'm just going to roll with it, because this is take 3, and it's time to roll. So the conclusions that they found is that postoperative pain is not influenced by the apical size of the preparation or taper size of the instrument. They found that minimal apical preparation size required to adequately disinfect the canals is a 2506 or 3004 in majority of the cases. And they found that further enlargement of the apical third to larger sizes and tapers does not influence or result in further significant improvement in success rates. They also found finally that the apical preparation only 2 sizes bigger than the initial apical binding file. So they found that the binding file was a 15 file, so 2 sizes larger would be a 25. And if they use an 04 taper, they found that that is insufficient and results in lower success rates as compared to preparations done with larger sizes and tapers. So how did this study work? That's the conclusions, take it for what it's worth. They took 120 patients, and this was in India. So with necrotic mandibular molars, they standardized it with mandibular molars, and they wanted to figure out if there's a minimum size of apical preparation and taper that will affect healing. So they used periapical radiographs, and they tried to see if the lesion healed. Pretty simple way of doing it. There's so many files on the market today, and so many biased papers, Facebook pages, mine included. Ninja cases, ninja this. It's crazy. So they wanted to find something and see if there's a minimum idea that's going to work. So what I think was really unique is that they tested what won't work. So, the people that receive the file size and taper that won't work, they got to get a retreatment, or they have to lose their tooth. And I'd say that that's pretty significant today. So I think that might be one of the influencing factors of how this article got published, because they're able to do this experiment, this research with techniques that are almost like from the 60s, where it's like, okay, you're going to get something that works, and you're probably going to get something that might not work. We're going to randomize it, but one of you is not coming out with great success. So it's actually, how else are you going to test these things? So the only way to, you got to take the conclusions of this article with a grain of salt, because the only way to verify that the conclusion of this article are true and valid is to repeat the exact same conditions, exact same study. So they found that they used all cases were necrotic, and none were vital. So we all know that necrotic cases are more challenging because of the bacterial load, or so that's what's postulated. And it makes sense. The apical deltas, foramina, ramifications, all, the isthmus, all this stuff is full of bacteria, and to try to get that heal with essentially man-made metal toilet bowl cleaners to get down to the end and try to irrigate, create a path so our irrigants could get down there and clean it out. It's pretty hard. So we know that vital cases, if you're less than 2 millimeters away from the radiographic apex, you're good to go. So the question is, would a 2504 or a smaller taper be good in vital cases? So that's one of the questions. What do you think? Put your comments below. So postoperative pain, they comment that postoperative pain has been noted in the literature to increase with increasing apical enlargement. And what they say is potentially from the irritation of the periapical tissues from extrusion of debris or irrigants of sealer. My thoughts also go towards length control. And I've struggled with length control through my entire career. And I thought I've had it, and then I go run through a case, and then I'm long, or I'm short. And especially in necrotic cases, why am I short? So, only God knows that trying to maintain length at 0.5 millimeters away from the working length is not easy. And I think it takes years of practice to develop a skill to not over-instrument. Contacted the patients to see how they were doing over the course of 6, 12, 24, and 72 hours. And only one patient complained of severe pain in the 2504 group, and an emergency intervention was scheduled. And according to the AE, that's called a flare-up. So what I like about this paper is that they subtract 0.5 to 1 millimeter from the apex, on the apex locator. And I think this is important as general dentists. We train our students, or our own students, to keep 1 millimeter back from the one bar on the apex to offer some buffer zone. And like I said before, they make the canal, I would say 80% of the time is going to get shorter as you slowly increase the size of your file and open up your canal. So keeping it 1 millimeter back will give you more confidence, and especially during your cone fit radiograph, and increase your efficiency. And trust me, I've made every mistake possible. So another point in this article, they use the PAI score, and you can take a look at what that means here. They also use 3% hypochlorite with a 27 gauge needle. In my thoughts, this could be a limitation as there are smaller irrigating needles available. So the 27 gauge has an outside diameter of 0.41 millimeters. So it would require an apical preparation of at least a 3004 to get within the ballpark of apical preparation. So that may be a factor, but it may be important, it may not be, because I was trained to use 30 gauge, so that's like a 032 outside diameter. You can see in the scale here, we're going to be talking, you can see the numbers right there. 30 gauge is 031. So does it make a difference? I'm not sure. Maybe. So the patients were reappointed in 1 week, and stage 2 of the root canal was completed then. Calcium hydroxide is placed in an intracanal medicament, and if you've ever wondered if you should use calcium hydroxide in vital cases, you should, because it dissolves vital tissue in isthmuses and may only help your cause. And then another question that actually I had on a webinar was, what about leaving sodium hypochlorite in the canals? And I thought about doing that in dental school, actually. I was like, why aren't we doing this? But then about 10 years ago, I learned that dentin has a really great effect on neutralizing and deactivating bleach. So essentially you have a pool of water in the canal in a short period of time. So there's no point in doing that. It's not effective. So using calcium hydroxide, whether you have a premix or a powder form, is better than just leaving it open, leaving it empty. So when the patients came back to have their root canals finished, the patients were inquired about any signs and symptoms over the past week, and then clinically verified by checking tenderness on percussion of the tooth. In the absence of any symptoms, a temporary restoration was removed on the rubber dam, and the canals were irrigated copiously with 3% sodium hypochlorite to flush out the intracanal medicament. After thorough cleaning of the canals, irrigation with manual dynamic agitation using gutta percha, they followed the rinse with 5 millimeters of saline. They obturated with gutta percha and a zinc oxide-based sealer using cold lateral compaction method. Post-endodontic restoration was done using dental amalgam. Using preset exposure parameters, a post-operative radiograph was taken with a parallel technique which served as a baseline radiograph. I have to say, I love the fact that they obturated with zinc oxide eugenol sealer and lateral condensation and had great results. So it really reinforces that it doesn't matter what you obturate with at all. It's really the quality of disinfection. The periapical radiolucency was compared using a periapical radius index score, PAI. And in case of dissimilar scores in individual roots of mandibular molars, the highest PAI score among the roots was assigned to the overall score. The radiographs were evaluated in a dimly lit room on a view box by 2 independent examiners blinded to the study. Okay, so what I'm going to do is I'm just going to read the discussion for you. If you're listening along, that's great. That way you don't have to read it. So the present study was designed as a randomized prospective clinical trial evaluating the effect of apical preparation, size, and taper on postoperative pain and the outcome of primary endodontic treatment. The primary outcome measurement was analyzed in 2 phases. In the first phase, postoperative pain following biomechanical preparation prior to obturation was assessed. A statistically non-significant difference in postoperative pain was observed at time intervals, like I had mentioned before. Extrusion of infected debris, irrigants, or intracanal medicaments in the periapical region has been cited as one of the possible reasons for postoperative pain. In this study, we limited canal preparation to 0.5 to 1 millimeter short of the radiographic apex while maintaining apical patency with a number 10 stainless steel file. I mean, this could be a reason, they state, for a non-significant difference in the incidence of postoperative pain among various groups. Other factors that might have contributed are the absence of preoperative pain, placement of calcium hydroxide as an intracanal medicament, and the use of rotary instrumentation. The patients can report a mild degree of pain for reasons other than the endodontic therapy, such as sensitivity to clamp placement, oh, that's a good point, sustained mouth opening, that's a good point, or local anesthetic injection. By the end of 48 hours, pain reduced substantially in all of the groups. 75% of patients had no pain, 7.5 only had mild pain. In this study, a significantly high success rate was observed with apical preparation 2 sizes larger than the initial apical binding file, and 6% taper compared to the same preparation size with a 4% taper. So we had almost 93% success versus 57%. However, the success rate was almost the same when the preparation size was increased to 3 sizes larger than the initial apical binding file with a 4% taper, so 92.8% versus 93.1%. In the majority cases, 70%, the initial apical binding file determined after coronal pre-flaring was a 15K file. Therefore, in the present study, the minimal apical preparation size required to disinfect the canals adequately was a 2506 or a 34 in the majority of cases. Further enlargement in preparation size or taper did not significantly affect the outcome of treatment. I think there's, you got to be careful with that, because if if your apical size is a 50, I'm telling you, a 3004 is nowhere near what you need to do to clean that out. Anyways, I digress. The importance of penetration of irrigants in the apical third for efficient debridement and disinfection cannot be understated. In an in vitro study comparing the effect of apical enlargement on the intracanal bacterial count, Cordero or Erel pointed out that removing dentin in the apical third may not be necessary if an adequate taper is achieved that allows satisfactory irrigation of the canals. In contrast, many in vitro studies have reported a reduced intracanal bacterial count and endotoxin level with increased apical preparation size. However, caution must be exercised while applying these results in clinical practice, as several additional factors come into play in an in vivo setup that may be absent in a lab setup. There's actually a brand new article that I was just reading today from Rikuchi that talks about XP Finisher versus Reciproc. So I'll post that if you want to read it, put it in the comments. We'll talk about that later. A significantly high success rate with minimal apical preparation and an increased taper attained in the study may be attributed to many reasons. Firstly, the increased taper allows better penetration of irrigation needle, they have a typo, the irrigation needle, permitting efficient debridement of the canals. The volume of irrigant delivered plays a pivotal role in the disinfection of the root canal system. Secondly, and this is actually one of the things that I've noticed in teaching a lot, is that brand new dentists unfortunately don't irrigate enough. And it's because it's kind of boring, to be honest. I mean, when I irrigate, it's fairly boring. Nothing's happening. So that be one of the causes. But I think the other problem is that you're so focused on just trying to get to the end of the root, get this thing over with, that it's like, well, let's just shortcut on the irrigation. So I think that's one of the key things. Like if you're brand new at root canals, take the time to irrigate at the right times. And the right times are after you have a main, you've got down to working length with a couple files. Not some, you need to open everything up. Go ahead and take a look at it. I'm just throwing a shameless plug-in for all things endo.ca. There's an endo course on there, fairly affordable, and it's going to talk about all this stuff. All right, I won't talk about it again. Secondly, so did I talk about firstly? Yes. Secondly, treatment performed in multiple visits with interappointment antimicrobial dressing may have resulted in effective disinfection of the canals. In a classic histopathologic study, it was demonstrated that an improved microbiological status was achieved by the root canal systems of teeth treated in multiple visits versus with a 1-week interappointment calcium hydroxide dressing. The anatomic complexities like isthmuses, fins, that's a tough word to say, dentinal tubules, and have been shown to harbor bacteria that are inaccessible to the mechanical instrumentation. In the present study, greater taper enabled easy placement of intracanal medicament until till the apical third of the root canal system. That could have been, well, that's kind of, this is a pre-proof, so we need a little bit of work there. In the present study, greater taper enabled easy placement of intracanal medicament to the apical third of the root canal system. That could have been a contributing factor for the better outcome. Lastly, minimal apical preparation enlargement with increased taper aids in the replenishment of irrigant in the apical third enabled by loose positioning of irrigation needle at the junction of the middle and apical thirds. So Boutsioukas et al. Demonstrated that the increased taper allows improved replacement of the irrigant and results in the distribution of shear stress of the wall apically to the needle tip, which reduces the risk of extrusion of the irrigant. Increased taper with minimal apical pressure, apical enlargement allows effective disruption of the vapor lock caused by mechanical agitation with gutta percha cones that snugly fit at the apical foramen, while at the same time provide space for irrigants to escape coronally. So what they did in this case is they're not even using sonic, they're not using ultrasonic, they're using manual dynamic agitation. Now you got to be careful with this because you can extrude stuff into the tissues, but I'm telling you, I've done it on clear plastic teeth, the manual dynamic. There's a video actually, it's super long and boring, but if you take a look, it's called Glide Path. I didn't even adjust the thumbnail. I learned there by doing manual dynamic activation. It's like, wow, this is actually pretty effective. But be careful you don't push everything into the apical tissues. So maintain your, I'm using the finger, so make sure you maintain your constriction. So all that, if you've blown open your constriction wide, which happens, you can still recover. You're going to force a lot of that irrigant into the apical tissues. So preoperative factors like the size of the periapical lesion is known to affect the outcome of the root canal treatment. In order to minimize the effect of lesion size on healing, only mandibular first molars with periapical pathology of greater than 2 millimeters and less than 5 millimeters were included in the study. Mandibular molars were selected for the study as they were the most commonly involved teeth with pulpal and periapical disease. The periradicular of the mandibular first molar can be predictably and repeatedly radiographed by paralleling technique, making the PAI scoring easier. And I'd have to agree with that because if you're taking periapical radiographs, taking your working length or your cone fit of an upper 6, that zygomatic arch is always in the way. I'm telling you, always in the way. But of course, they talk about using a cone beam. Let's continue. Significantly better healing has also been associated with certain postoperative factors like the extent and quality of obturation and the optimum coronal restoration after endodontic therapy. In this study, the obturation was terminated within 0.5 to 2 millimeters of the apex, like I said before. The quality of the coronal restoration was verified postoperative in every follow-up interval by the operator as well as the supervisor of the study. Before deriving conclusions, I love this part of it because they talk about limitations. The limitations of the study must be taken in consideration. Smaller sample size, only 120, shorter follow-up period, only a year. Use of periapical radiographs for determined success, no cone beam, and determination of apical enlargement size based on initial apical binding file, which I couldn't even tell you how to do because I'm not that good at it, may be considered as limitations of the study. Studies with a larger sample size and longer follow-up periods are required to prove the association between apical enlargement and the outcome of treatment. Also, three-dimensional imaging may be better for evaluating the change in periapical radiolucency. The initial apical binding file may not represent the actual diameter of the apical region due to the high anatomic variability of the apical third of the root canal system. However, early coronal pre-flaring enhances the tactile sense of the apical constriction and diameter by reducing file contact with the canal walls, providing straight line access to the coronal middle thirds. The determination of the initial apical binding file after coronal pre-flaring might provide a better estimation of the apical diameter as done in the present study. So conclusions, we'll just go over this one more time. Within the limits of the study, the conclusions can be drawn is postoperative pain is not affected by the apical preparation size. Apical preparation, two larger sizes than the initial binding file of 4% taper is not as effective as using the initial apical binding file, two sizes greater, and an 0.6 taper, or essentially, you know what, open everything up to a 25.06 or a 30.04. With that, we're done. Anyways, I really appreciate your time here. Don't forget to subscribe, share this with your friends on your choice of social media. And let me know if you have any questions, and let me know if going over types of articles like this is really helpful. So anyways, we'll talk to you soon. This is a wonderful patient, Julia. She was about 70 years old, and she had tooth number 17, and she was expressing pain to this tooth. Now, Julia is a very great patient because she had a couple root canals completed previously, and you can see there's this beautiful threaded post, like boom, right in the middle of that tooth, and she has an apical lesion. Now I asked her, we had a cone beam taken, and I'll go over that in just a second. And the reason why we had a cone beam, she's extremely nervous. And I said, well, why don't we take a cone beam just to make sure there were 4 canals? She said, yeah, let's do it, because she had a canal missed in another tooth, potentially even this. Well, it's there. But so we had the root canal. So we had, that's the problem with cone beam, is that you can see so much, but then there's things you don't want to see that you need to approach a patient with. So I talked to her about this lesion. She fully understands it. She has the report. But because of her fear, she's just going to wait out. Because I asked her, how many years ago did you have that? And she said, it's been many decades she had this root canal. So knowing that everyone loves to wake up and get a root canal, she totally declined getting that retreated at this moment. But she was fully aware of some of the concerns. So here's the cone beam that we took. And where I live in Ontario, we get a report completed by an oral maxillofacial radiologist. So it's a nice backup. We'll just look quickly. This is a coronal section of tooth number 17, and you can see there's the mesiobuccal 2, there's the MB1 in the mesiobuccal root. So if you're not familiar with looking at cone beams, this is the kind of where the cheek is. This is the buccal cortical plate, and this is the palate. Palatal root, palate right here, whatnot, and the maxillary sinus. And this is our axial slice. So you can see MB1 there, MB2, there's our distal buccal, and there's our palatal. So you can see that not only, I'm definitely not an expert. I can kind of weasel my way into seeing how to read these. But you can see here are the 2 canals, and then just by not only the root form, but also it appears that the root gets really small. And this is in the way that they join. So that just messed up my picture here. Anyways, so I'm already ahead of the game by knowing that we have an MB2 in the tooth. So we know to look, and we know that they likely join. So that speeds us up quite a bit. So let's go ahead and access this tooth. So the question I have for myself is, why is this tooth necrotic? That was the diagnosis. She experienced significant pain about 2 months ago, and then it slowly died down, and now it's necrotic. So, and when we entered in the tooth, it was necrotic as well. So the first thing I'm going to be looking at, this pin looks a little bit close, potentially to a pulp chamber, to a pulp horn previously. Maybe just leaking restoration over time, but maybe it was a crack or fracture. So we talk about that. And we look at the tooth here. I don't see any fractures. Obviously, this is composite restoration, but we're going to be looking briefly underneath that restoration as well. So I'm going to go dry in this case. And I got to warn you that this is the first time with this microscope camera, because I had to get a new one. So it's going to be a little wonky. So what I'm doing here is I'm removing some of the restoration quickly, and I'm just looking to see if I have any fracture marks. Not a lot. And then what I do, because the burr is chattering, so I stop right there, I take a really quick look. The burr, she's really nervous, and the burr's chattering a little bit, so we went right into the pulp chamber quick, and then we're in, and then we're going to take our endo-Z burr, our non-cutting tip burr, so you can see this is the pulp chamber here, and then we're just going to open that up with my endo-Z burr. Normally I go wet, but we're going to go dry just so I can see what's going on, so I can do it a little bit quicker than normal. And the problem with going dry is that it can burn the dentin, so be cautious with that. So let's take a look at what we have here. All right, so just right up front, it looks like a mess, doesn't it? So I'm looking quickly, I'm looking to see if there's any fracture line here in the pulpal floor. There isn't. I'm looking, you can't see it but from the microscope camera, but down here I'm looking to see if there's a fracture. There isn't. So the next step I do is, because this looks kind of messy, here's our distal buccal, there's a mesiobuccal 1, somewhere around here, this is our palate. I'm going to take my Waveland Gold and just use that as my orifice opener real quick. I have a lot of confidence in reciprocation, so boom, there's our first, that's our palate, cleaned it out, and what we're doing is we're cleaning up the middle, the coronal and middle thirds. So we're just trying to get into our distal buccal, you can see it right there, that's pretty quick. And you notice I don't take any hand files, and that's the quickest way I've figured out how to do this without getting hand files in there. Just open up the coronal 2/3, And then we'll get into our mesial buccal one. Let's just do that slow. That's a little bit speedy here. So there we go there. And then we're going to irrigate. Well, I guess I didn't get that back. Anyways, we're going to irrigate all that mess out of there, and let's see what we have. So we're using full strength sodium hypochlorite, and I actually have a 10 milliliter syringe, 12 milliliter syringe. It's amazing. So I don't have to, my dental assistant doesn't have to keep refilling, and I'm working with Justine. She's amazing, amazing dental assistant. So what am I looking at here? We've got no fracture in the pulpal floor, no fracture in the mesial wall. So it could be just leakage of that restoration. Our palatal canal, distal buccal, mesial canal, and I'm going to be looking for that MB2 because we know it's around there. So we're just cleaning up. Actually, I'm just showing Justine because the camera is new, and what's the problem that I'm running into right now, you're seeing, is that the focal length is too close. So I'm actually, anyways, the tooth is too magnified for, this is the lowest magnification to be able to see what's going on adequately. So what we're going to do now is we're going to, let's just see here, that was MB2, wasn't it? So you can see MB2 right there. I was thinking I was poking at that. It looks different in the scope because it's at a different angle. What happens is the camera is actually, it appears the camera seems to be peering down one of the binos, one side of the bino. So this is actually MB2, and I'm going to open that up. Let's just see if that is it. And then I opened it up, and then what I did was, don't do this. I started taking my hand file. You can see how the file looks so magnified. This is my lowest magnification. And I had a bunch of debris, so don't do that. So what we're going to do is I always take a 6 file, but what I'm going to do is I'm going to irrigate all that out. And then let's do that, much better. Okay, so we're going to find our working length, pretty simple. So we take a 6 file, then we're going to take an 8 file. We're just going to watch wind it down to length. Take my epex actually, get my working length. And this is a pretty straightforward case. So everything kind of dropped right to length, no problem. Working lengths were roughly around 19 to 20 millimeters long. And I apologize. So you can see how this file is so magnified. I've changed my focal length, a different lens, magnifying lens, so it should be a little bit further back for the next video. And then we're going to take a 10 file, get my working length. And that's pretty much standard for all the canals. We're just going to go 6, 8, 10, 6, 8, 10. There were no real significant snags in this case. So then what we're going to do is rinse that out, and let's take a look here. So irrigate that out. And so you can see MB2 is right here. So it's actually pretty straightforward. So we know that using the cone beam, it was really, really helpful. It's like, okay, boom, it's here. And then once you get in, you look for it, and again, it's set. So we're going to take I've got my working lengths. I've got a glide path. It was really quick to make a glide path in this case with a number 10 hand file. So what we're going to do now is we're going to fill our chamber with irrigant, and we're going to start opening our entire case to a 25 file. So I'm going to tackle all main 3 canals with my 2508 primary. You can use whatever file system you like. I've been using Wave and Go for a long time. I don't get paid by them. And you can see here, I actually, for some reason today, we ran out of 25 millimeter lengths. So fortunately, if you memorize these, you got to be careful, but they're 18, 19, 20. So I'm using, it is 20 millimeters. That's what the length was. So I'm using the band on the side of the file just for my length. So what I'm doing is I'm coming out of the tooth, and I was talking to my buddy, Dr. Whale from Egypt, and he does a very similar thing, but he does a continuous irrigation protocol, which is really cool. So check him out on Facebook. And what I'm doing is I don't do continuous. I find that with the Endovac, there are way too many hoses. It's a great product, but there's way too many hoses. So what I do is I find that by just bringing the file out of the orifice just a bit and then running it in the irrigant in the pulp chamber, it drops off all the debris drops off the flutes. And then you can keep going because I keep progressing apically. Now the problem that I find is that if you don't clean your flutes, you're just, you're rubbing two structure on two structure, and you could potentially increase the probability of fracture. And that's what we call torsional fracture. So it's really if you take two, same sized cups, like plastic cups, like beer cups, like you're at a beer tent, and you have two cups and you try to rotate one and the other if there's no beer in it. They're really tight. And that's what happens when you're, it was told to me by actually Dr. McSpadden's son. I was on the phone with him a long time ago, and he was talking about torsional fatigue. And it's really not cleaning your flutes, and the flutes full of dent and debris rubbing against the tooth. So that's why you got to keep your flutes. That was the moment where I was like, man, how can I keep my flutes clean quickly? And this is one way you can do it, is just keep your pulp chamber full. And you can see all the debris that gets washed out. And I'm using the irrigant in my pulp chamber to clean out my flutes. I do that mainly like 90% of the time, and the only reason why I do it, honestly, is efficiency. There's no point, I find, unless you're like Dr. Ali Nasseh and you've got your single swipe technique. You've got your dental assistant with that little swipe technique. It's great. I find that this is just a quick way of doing it. So I'm just checking patency here. I'm going to recheck my working length as well, but I won't recheck my working length right at this moment because my pulp chamber is full of irrigant. So I'm going to get, there we go. So you see Justine dries it a bit. So I've just got I've got irrigant just in my pulp chamber. We check our working length. And in this case, we didn't see a big discrepancy between the primary, after primary, because there weren't a lot of curves. It was a pretty straight case between before primary working length and after working length and after primary. And if you've got curves, there can be a significant change up to almost a millimeter in working length if you've got significant curves in your tooth. So I'm just going to speed through here because we're just checking patency, and we're also checking for working length. Now, patency is an arguable situation. I'm not going to get into that. I do check for patency, and I am typically going to one red bar, but Dr. Ricucci has I just listened to a great lecture from him at the AAE, the virtual conference, talking about no need for patency. And it's such a hard thing to get away from. Do I believe in puffs? Not really. But I can tell you that getting away from patency is a hard situation. But I will go away from it in cases that are vital. So if I'm battling, because what I find is that, the last millimeter, you could have some sort of crazy delta, and trying to break into it is going to be really difficult. So what we're going to do here, as you can see, is I'm not tackling MB2 yet. I'm still going with my working length. I'm going to full working length with my 3506. I'm a little bit off the screen. My sincerest apologies. Let's pull that up here. Again, the problem with this new camera. What happened was I sold my old camera by accident, literally, and then I was camera free for a while, and I wanted to get a new camera, so I needed to slowly save my pennies and put it together. So now I have my camera, but I had to change my the working length, the focal length, sort of a little bit. We're way too close right now to get a great shot. So here we are. We're doing our working length. I'm doing final shaping with my Wave 1 Gold primary, medium, and what you saw there was I'm checking to see if there's debris. So I'm getting cutting on the apical portion of my flutes. So I'm happy with that. I'll run it, once I do that, I'll run it one more time down the same canal just to make sure that I get a great clean machining of that. It is a necrotic case. Does that increase my outcome? I don't know. Take a look at that article. Actually, they had some interesting comments about making sure that, the real key, what we're trying to do is make sure we have adequate debridement not with files, but with our irrigant. And that's really the key. So take a look at that article. Put in the comments what you think. Let me speed ahead here. So while we're waiting for this guy to tackle MB2, let's irrigate that out really well. And what I'm going to do now is let's go for MB2. So there it is right there. So what I've done is I've actually moved it a little bit more mesial and with my Munzber. So I'm going to take a 6 file. Now I'll take a 6 file, and I know that there's a high probability of this canal joining MB1. It's almost like certain based on the cone beam. So I'm going to find, probably likely what I'm going to experience is a little bit of resistance up front in the coronal portion, and then it should drop. It will seem to drop. I'm expecting it to seem to drop in the apical third just as it joins. So we've got it going down normally, and I think in the video what happens is it doesn't look like it's moved that mesial, but under the scope it's moved actually quite
I'd move the orifice much more mesial. So we're going to do our 6, 8, 10. I think the 10 just dropped right to length. And then what we'll do is we'll get a working length. I do it just because just to make sense, just to make sure that just in case they don't join. And then what I'll do is I'll do a quick glide path with my 10 file, and then I'm going to take my primary and head south and get this case over with. So as you can see, what I've been doing, and this is what the experts have taught me through years of doing this, so I'm just going to be doing, there's my, let's slow this down actually because it shows exactly what I'm talking about. It's open, so I'm bringing, you can see I'm bringing the debris out, letting the flutes empty in the irrigant, back down. Irrigant, come out, back down. Come out, back down. So it's a continual process, and what this does is it speeds everything up because now I'm not taking my file out and getting my, cleaning it in my sponge or getting my dental assistant to clean it or whatnot. It's a lot quicker, I find. And I'm actually a little more aggressive on this because I know that it joins, likely, MB1. So I'm going to drop right down, and I'm not going to open this up more than a primary. Normally MB2, I'm going to stick at a primary, just because I'm concerned with strip perfing. I have a video coming up, actually. I sectioned some teeth and taking a look at strip perfing those, the probability. There's actually a great article. I'm going to add it to this because I was thinking about it, because it's about premolars and making your access too small. And that's the same as molars. Making your access ultra conservative increases the probability of strip perfing or missing debris or whatnot. So I'll put that in there. It's a really great article. We all want to keep our teeth super small, just like Facebook, and definitely not this situation because I've opened it up to remove some of the restoration. Because what I've found is you can miss stuff, and I've done it myself. So I'm going to reconfirm my working length of my MB2. Let's speed through that. And then what I'm going to do is, I think I'm going to check my irrigation. I'm going to run it back down one more time just to make sure we're cleaning debris. Because what happens is, sometimes when you run the canal, let's see here. We'll irrigate. I'm going to aspirate my irrigant from 1. So lots of irrigation. I'm using a 30 gauge irrigating tip. Full strength hypochlorite. And let's see, I'm going to aspirate at one of these points. Sometimes watching your own stuff gets pretty boring. It's like, what is going on? Even if it's a recent case. All right, so I'm going to aspirate that irrigant, see if it goes down the MB2. So at that point, I saw that and I was like, oh, maybe they don't join. There's a probability of them joining. Also, the apices may not join, but there might be an isthmus. So you got to be not worried, but be concerned. Take that in consideration when you're doing that aspirate your irrigant. So when I saw that, I was like, oh, maybe they don't join. So I'm going to reconfirm, because sometimes if they do join and you shape one of them, debris goes into one of the other canals. So it is what it is. So what you're seeing here is actually my manual dynamic activation, so MDA. And quite frankly, I'm going to be using it in this case because I forgot my endo activator at home. Literally. It was in another one of my cases. I have a mobile case and I forgot it in the other case. So I'm going to do a manual dynamic activation, which I found actually if you want to see how it works, I actually put a video 2 years ago. It's super long and boring, but in it talks about glide path. And I never really believed in manual dynamic activation until I did it on a clear tooth, and I couldn't believe it. Actually, it worked most effective out of sonic irrigation activation versus nothing versus that. Just empirically, just monkeying around with a clear tooth. So that's what we're doing here. We're just doing our manual dynamic activation, the MDA, a few times. Just pumping. You got to be careful. Try not to pump any of that sodium hypochlorite into the soft tissues, or not in the soft tissues, in the apical tissues. So I I almost have the canals dry. And I'm going to run that one more time because I wasn't getting full working length. So that's a little tip there. So I wasn't happy with the full working length of my file. So I pulled it out. You can see there's a couple bends. Let me do this again. So I wasn't happy. What I'm going to do is I'm going to take my wave on gold. You can put it in your hand and do it. I'm just going to run it past my working length a little bit. I wasn't happy with the length I was getting, and then I'm going to look for debris and see if I'm cutting any debris along the flutes here, because this might actually be binding my gutta-percha point out. Now, the gutta-percha points are not perfect. These are laser cut, but there's always still, I mean, it's rubber, so it might still be a little bit off. And you can see there's, let's see if I can get this right. So there's like there's my initial bite, so I made an indent to make sure that when I seat it, I know exactly where I'm seating. And then I'm going to try to grab it again and see if I get a little bit extra length. I'm looking for, I think it was a 1/2 mil long, and I think we were good. So I think I do my aspirate my irrigant trick again, and it did work. Yeah, so it moved, so they are joining. So lots of irrigant. So what I'm doing here is this is after I did the dynamic activation. I'm taking my tip, I bent my tip to about 2 millimeters short of my working length. I'm checking. So it's a side vented 30 gauge needle. Oh, you can see the aspirated right there. So that kind of made me feel like, oh, well, they do join. But I'm trying not to fake myself out with an isthmus potentially. So we're going to withdraw all that. I'm going to rinse with EDTA. We're going to rinse with 4 to 5 mils of EDTA. Same thing, you see I have my needle tip bent. Rinse that out. I didn't activate that. And then actually, I skipped it here in the video, but what we did is then we rinsed with sodium hypochlorite final rinse, and then we're going to dry. So let's take a look at what we have here. So we've got our MB2, and again, we're still looking for any fractures, especially along the furcation, floor of the pulp chamber. So there's MB2, there's MB1. Beautiful. There's our distal buccal. I'm just showing Justine actually. It's the first time she's seen it through the computer. I'm just running it through my Mac in the operatory, and there's our palatal canal. So we're going to do our single cone technique. So what we're going to do in these cases where I get a great working length, I'm happy with everything. My apex locator, it's 8 teeth, it works like phenomenal. I'm just going to place sealer on my canal. And actually this is interesting. I kind of switched my technique. I used to inject, but you know, Dr. Wales sent me he sent this picture a long time ago. Let's see if I can find it real quick. That he got an email from someone, and this is the situation that they had. And what happened was, they kept injecting, and every time they looked down the canal, it'd be empty. So they kept injecting with the BC sealer, and then they took a final x-ray, and they're like, oh my gosh. And the patient started feeling a lot of pain, so finally the tooth was extracted, and I think they had to irrigate all this out. And I can't remember what happened. Anyways, the tooth was extracted immediately after this. You know, it's like, you know what, I'm going to try just kind of washing it with my gutta-percha point, and actually, to be honest, it makes no difference. So it's kind of less BC sealer, and I have a little more control, which actually I prefer. So here, so what I've done is I've placed my distal buccal MB1. MB2 goes in. It doesn't go all the way to length, so I'm like, okay, let's just see if I pull my MB1 out, it goes all the way down. Now the other way you can check to see if this works is if I were to take a 15 file, place it down, and see if it perforates the MB1 canal. I wanted to get this case over because the patient was fairly nervous, and we were getting to the point where we needed to get over with. So this is taking the x-ray, and then what we're going to do, I didn't take a picture of it. What we're going to do is we're just going to do our single cone burn-off technique. This is again with our 8 teeth fast pack. So it's pretty straightforward. We're just going to sear everything. I'm using 250 degrees of heat. I'm using a large tip, and then I'm going to take my plugger. This is actually a Buchanan plugger, and someone, when I wasn't there, working there, they took a heater and tried to use it, and they bent it. It's really funny, actually. It's quite frustrating to use. You can see how it's heated up. They tried to use it as a heat element. Took a flame and heated it, but that's okay. It's no big deal. So we're just packing that down. We're going to give it a good rinse afterwards. Big rinse, and then we're going to take so this is what we're left with. I'm going to take our 8 teeth fast pack, remove some more of that, and then pack it down, give it a just burnish, seal up the orifices, and then place our provisional restoration. So there's our palatal canal, there's our distal buccal, there's our MB1 and MB2, place an orifice barrier. So let's take a look at the periapical radiograph. So that's pre-op. This is our shift shot. So this is a distal shift shot, and what that does is it allows us to see the mesial root, MB1, MB2. This is our distal buccal, and here's our palate. It's a real super shift. Here's another distal shift shot, but our distal buccal is lined up over our palatal canal. You can see a little bit of a periapical radiolucency there, and that's it. So with that, hopefully that was helpful for you, and don't forget to like, subscribe, and we'll talk to you soon. Cheers.